Spinal cord injury. For this PowerPoint, I am just going to be covering the basics of this. I'm going to go into complications on its own separate PowerPoint because it's very important to just get this concepts down and just the essentials of it. The complications, I want their own little special PowerPoint to focus on. Concepts of spinal cord injury. Think about the neurotransmission. There's going to be a disruption and impairment of that, especially where that injury occurs along that vertebral column. If it's higher up in the cervical area, everything below that is going to have interruption. Perfusion, whether it be because of the heart not pumping enough because it has decreased cardiac output, or because of the body's compensation where it's pooling blood to the spinal cord, to the site of injury. Oxygenation, again, depending on where that vertebral damage is, that spinal damage is, you could have impairment of the lungs, just the muscles to allow you to breathe. Okay, and this is a very life-threatening condition. It's very life-threatening and emergent, okay? And some of these patients need to be intubated. Again, bleeding is a problem, especially when it gets into that spinal column and it compresses on the spinal cord. So you're going to have hematomas, and it can do some nerve damage as well, especially as you'll see what incomplete and complete sever or damages. And then clotting, again, that is going to be more so with some of the complications when blood is pooling because of the decreased cardiac output, because you're going to have a change in the sympathetic nervous system and the parasympathetic nervous system. And you're going to see like a drop in heart rate, a decrease in cardiac output. And it's just where the blood is pooling, and that allows for clotting, okay? And again, inflammation and immune response. So anytime there's injury, the body is trying to get those mediated cells out and those receptors, and they go ahead and they produce this inflammation, and that can do more damage. And actually just think of it as like increased cranial pressure, but for the spine. It should be like increased spinal pressure, ISP, honestly. And then you're going to see a fluid and electrolyte imbalance. And I always go hand in hand with acid-base imbalances. So think of that for a minute. Why would there be fluid and electrolyte imbalances? This might be a tricky one to look over. And of course, immobility, that's obvious. And without mobility, think about skin breakdown, especially if you have decreased sensation. You can't tell if you have a damaged foot or if you stubbed your pinky or whatnot, okay? And with those, electrolyte imbalances, you're going to see that, especially if they have like NG suctioning. And I could have added another one, like metabolic regulation. There's going to be increased metabolic needs just because the body's in a constant state of repair, and you're going to see this hypermetabolism occurring, and they're going to need, better intake of their nutrition, okay? The patho is really just traumatic injury to the spinal cord, which results in impaired functioning of that neurotransmission, and it is often permanent damage. Now, some of the causes could be a motor vehicle accident, most common actually, falls, those are the top two. Sports, really heavy contact sports like your football, acts of violence, and then penetrating wounds. And then you have primary versus secondary injury. So primary is that initial damage. And just like with strokes, you have those primary and secondary. It's the same concept. So you have the secondary injury, which is really the body's response and how it tries to compensate. And it really just does more damage. And then you also have complete versus incomplete transection or severing. And honestly, to me, when I was younger, anytime someone injured their spinal cord, it was automatically assumed that they were going to have just complete loss, just complete paralysis, as we went along and discovered more on how to treat it and prevent that secondary damage. I think we're seeing a lot more people recovering from spinal cord injuries. So it's a good thing. Primary injury, that's the actual injury itself to the spinal cord. It is the first injury that can cause that permanent damage, okay? And as you can see right here, here's that primary injury. That's where that impact occurred. It's that initial mechanism, that disruption of those axons, okay? As a result of stretch or any laceration, and this is that primary injury. Now, just think for a minute with secondary injury. That is the body's response to this primary injury. So what it does is it just creates a complication, and it just further exacerbates that spinal cord injury. And then that can lead to hemorrhage and inflammation. And then eventually all that edema, it builds up. And then what does it do? It keeps compressing that spinal cord. And that spinal cord needs oxygen too. So then it becomes hypoxic. Those spinal nerves get hypoxic and deprived of oxygen. And then this can lead to that permanent paralysis and that cell death if it goes untreated. Okay, so that's that progressive damage. You can see it right here. It's like it's just swelling up, okay? But the good thing about that is it can be reversed if treated within the first 4 to 6 hours after that injury. So just think about that for a minute. What do we want to do? Well, we want to prevent that secondary injury. That is the hugest thing. And time is absolutely essential in regards to that. This is another slide to show the events leading to secondary injury. And in this one specifically, it goes over hemorrhage. And you can just see the pathophysiology of that, where, the clotting, the breaking down, the immune response, what's going on. And it shows all this. I'm not going to read every single one of them, but you can definitely see how it will cause swelling, how it will impair and compact and actually compress that spinal cord and deprive it of oxygen. So you're going to see tissue hypoxia. So just look over that for a minute. I mean, edema, constriction, everything is going to deprive that spinal cord of oxygen. And like I said, it's just the same as you would see with intracranial pressure. Okay? As we go throughout and we see where at on the spinal column that damage has occurred, you have to also take into consideration, was it a complete transection or was it an incomplete transection? Complete transection is really just completely severed of it. You lose all motor and all sensory function. Incomplete, that's that partial sever of the spinal cord. And again, depending on where on that spinal cord that has occurred, you can lose either that sensory or motor function. And even to those as a degree, you can either lose complete sensory or complete motor functioning. And again, like I said, depending where and to the extent on that spinal cord, you can lose some of that sensory or full sensory functioning. Or you can lose the gross motor functioning or the fine motor functioning. And really, this just classifies that types of injury. So you have the mechanism of the injury. And this is just how that occurred, okay? That flexion, hyperextension, flexion rotation, which is just awful. That's like a twisting. Extension, rotation, and then the compression. And then you have the level of injury. Is it skeletal or is it neurological? Okay. And then the degree of injury. And like we said, that's that complete or incomplete. All right. Mechanism of injury. And off to the right here are some pictures of them. So we have hyperflexion. And you can see where that chin is kind of towards the chest and it's flexing. And a lot of times you're going to see the cervical spine involved in these damages. Vertical compression, that is where those compress down. And you can have head injury as well. And that could be anywhere along the back in multiple areas. Hyperextension, a lot of times this is seen in a motor vehicle accident. They'll start out with hyperflexion and then hyperextension. Penetration is obvious. It's a penetrating object. Somebody lands on something and it just completely, can partially or completely sever that spinal cord. Flexion rotation, it can be flexion or extension rotation. This is the worst of its kind, honestly, because you're doing two different things. You're flexing it, so you already have that, and then you're rotating it, so you can just twist, and you're going to get a lot more inflammation and everything with that as well. And you do have to consider, again, are these incomplete or complete injuries? That's going to determine the care and the limitations and abilities of the patients that are going to have these. With the level of injury, just have a broad sense of this. You don't have to memorize everything, but do know that the location of injury will determine the extent of what loss or injury will occur. So if you see like the C1 and the C2, it's right there next to the brainstem, and you're going to see effects of the respiratory system, okay? C2, C3, you might die immediately or require long-term, intubation of this. And that's typically like Christopher Reeves has, okay? And always think with cervical injury, you want to monitor that respiratory status, okay? That's part of the ABCs. You're going to provide interventions for a patent airway, all right? And the higher up the injury, the greater paralysis will be below that injury, okay? Below the cervical will affect the arms and below. And anything below the thoracic region, that's going to involve loss of function below the chest, bowel, bladder, okay? And below the lumbar, just below the waist. So think of the legs. So you're going to have just paralysis of the legs. And there are some terms as well. Tetraplegia is a new term. It used to be called quadriplegia. And it is injury above that C4, okay? And you're going to have complete paralysis below the neck. Okay, and only a quarter of injuries are from tetraplegia. And quadriparesis that's when all extremities are affected. And then you have paraplegia and paraparalysis or paraparesis. That's the lower extremities. Okay. Our initial assessment with these patients is going to be emergent. And initially we want to ensure that there is a patent airway. And we want to do that by stabilizing that cervical spine. We want to stabilize that neck with a hard collar or C-collar, they call it. They might need oxygen or be on that nasal cannula. Sometimes they can get on a non-rebreather. We want to be able to oxygenate them as much as possible. And we need to establish IV access. And usually that's done with 2 large bore catheters. We're going to be giving them normal saline or lactated ringer, whichever is appropriate. And we want to make sure that we get that fluid volume balanced, okay? Especially if there's hemorrhage going on. And then we want to assess for any other type of injuries. Some of them are going to be obvious and some of them aren't going to be so obvious. They could have some internal bleeding going on that we're not aware of. We might not know until we straight catheter, do a straight cath on them, and we get a lot of blood in them, okay? And then we want to do is control those external injuries, until we can get that spinal x-ray CT scan to see exactly what's going on. And we'll talk about this. We're going to prepare them for stabilization with the tongs and traction. That's what this is over here. You have that cervical injury, or you can do a surgical stabilization where they put this halo on you. Okay. And so the ongoing monitoring, we're going to be looking at their vital signs. We're going to be trending them, doing their neural assessments, those level of consciousness. When they came in, were they unconscious? And now are they, conscious? Do they know where they're at, who they are, and whatnot? And we're going to compare that. And we're going to be doing that quite frequently. And we're going to be monitoring their oxygen levels, especially if we're giving them oxygen as well. And we want to make sure that we are assessing that cardiac rhythm. We need to know if there's anything going on, especially when you're talking about their parasympathetic nervous system, that fight or flight, or the parasympathetic. So you have the sympathetic and the parasympathetic nervous system. So we really got to look out at that cardiac rhythm. Their I's and O's, we want to make sure that's appropriate urine output, and we want to keep them warm. Urinary retention is a big one. So we're going to have to, make sure that they don't do that. And you're going to see in some of the complications why we do that. And we're looking for hypertension. So urinary retention is going to lead to the hyperreflexia, autonomic hyperreflexia that we'll go over. And they're going to get extremely hypertensive. So we want to prevent that, okay? And then when they're showing up with us, this emergent type care, we want to anticipate for intubation. If we don't see a gag reflex present, then we're going to have to do that, okay? Our goal is just to get them as stable as possible until they can be transferred to a medical facility. But first, they have to be stabilized before we can even think about the transportation process, And once they do get stabilized, we really need to get a history of the incident. How did it happen? We really want to emphasize, how extensive that injury is and perceived by that patient immediately after the event. So they could tell you things like, I lost consciousness, I don't remember, I couldn't feel my legs, but now I can, I couldn't with my arms and now I can, or I felt tingling things. Our assessment really does involve testing larger muscle groups first instead of individual muscles. So you want to test like the muscle groups against gravity, test them alone, test them against resistance, and you want to check it bilaterally. So we're going to, make sure the right and the left are, side of the body are, moving together. And then you're going to have to notice too, is there any spontaneous movement going on? You might ask the patient, to move their legs and then move your toes. And then you're going to have them spread out their toes. And then you're going to have them test their arms. Move your arms, move your wrists, now move your hands and spread out your fingers, okay? And then so just think about it. We're going from large to small muscle groups, okay? And after we've been able to assess their motor status, then we're going to look at their sensory. We're going to check and see how much pressure they're able to feel. Do they feel the sensation of soft or hard? You might want to prick them, to see if they feel that sharpness. And when you do the sensory, you're going to start like from the toes and work your way up. So that's how we always do that. And then we're going to want to do a thorough assessment associated with any brain injury, especially if it was with the cervical damage, if there was any spinal cord damage that was high up near the neck. So we're going to want to look at, the history of consciousness, any signs of a concussion or that increased intracranial pressure. That's really going to be important. And then overall, we have to look at these other injuries that they might have. How did they wind up here? How did they get injured? What was behind that trauma? Do they have broken ribs? Do they have anything else? Any bruising or tenderness? Any swelling, And because some of these patients have no muscle, bone, or visceral sensations, the only clue to some of this internal trauma could maybe be looking at their vital signs. Somebody might have some hemorrhage, so they might get excessive heart rate. Maybe their blood pressure goes really down or really up. They'll get that breda or that tachycardia where their heart rate just goes up. Okay. And then we're going to look at their urine. So obviously, you're not going to be able to look at the urine unless you straight cath them. Like I said, you might see some blood coming from that. So that might be some indication of that internal injury. And another really important thing is that we want to keep their spinal cord moved in an alignment. And that's why we do that log roll. We're going to keep their head and neck stabilized. And that's when we have to transfer them. And you can see at this picture here, they're doing that log roll. Okay, we want to prevent any further injury or any secondary injury, until we can get them to imaging, until we can see on a CT scan what really is going on, okay? And we want to do thorough monitoring, just continuous with these patients, They might end up going directly to surgery following any immobilization and stabilization that's done. So, or they might go to an intensive care unit initially until they can manage them. And I threw in the dermatomes. If you see where these cervical, spine vertebrae, and all of the thoracic, lumbar, you can see where these parts control the body, okay? So that kind of just gives you another idea of visual. So if there's any, injury here, it's below that, okay? Nursing assessment. I pulled this information right from the textbook, and I went in the priority order, okay? And as you can see, it starts from the cervical, and I work my way down. The later slides aren't in that order, but I kind of just wanted to sum it all up and then go in and deep dive more into it, okay? So we know the ABCs of priorities. Respiratory is number 1, okay? So after we have them stabilized, that's key to that as well. But, so we have this injury at C1 and C3 of the cervical spine. They're going to have total loss of respiratory muscle functioning, okay? You're going to see apnea. They have an inability to cough. And they're going to be on mechanical ventilation, okay? Injury at C4, you're going to see poor cough. You're going to see respiratory insufficiency, really. They're going to have that diaphragmatic breathing and hypoventilation, all right? And then injury at C5 to T6, they're going to have paralysis of abdominal and intercostal muscles. So just think about what the purpose of those are. That's to expand that diaphragm, the abdominal, everything contributes to, that respiratory reserve. So that's how we're going to see it decreased. And then they're going to still have that ineffective cough. And really think about what the cough's purpose is to move secretions out. And when they can't do that, they're going to get that atelectasis. So those little alveolar sacs are going to be collapsed. And then the mucus is just going to sit there and it's going to cause a pneumonia. So they're going to get infection. And then we'll talk about neurogenic pulmonary edema as well. So those are the A's and B's, okay? And then cardiovascular, we know that's the circulation part. And any injury above T6. And that's where we're going to see a decreased influence of that sympathetic nervous system. All right. We're going to see bradycardia, hypotension, postural hypotension. Okay. I mean, these folks are going to have massive vasodilation. Just, they're going to have a decreased venous return of blood to that heart. And they're going to have decreased cardiac output. Okay. And just think about that for a minute. With all of that going on, you have almost kind of like cardiogenic shock. It can't push its way through. And it's just going to cause that pooling. And then you can get blood clots. So they're really at risk for that. And they're at risk for pulmonary embolism, So then that goes back to respiratory. So all these are hugely important. And that's why I have these as the top two. And very close is neurogenic, okay? Just because it can, depending on where it's at on that cervical spine, where that injury is at, and if it's complete or incomplete. So if there's a complete sever, you're going to see areflexic, so no reflexes, flaccid, paralysis, and it's just going to be below that level of injury. Especially if it's above the C8, they consider that the tetraplegia. So they're paralyzed from the neck down. Paraplegia is considered injury below that C8. And they're going to have hyperactive deep tendon reflexes. And they're going to be bilateral. Okay. And you're going to see a positive Babinski test. This is after they went into spinal shock and they've recovered from that. And then we talked about the incomplete sever of the spinal cord. They can have mixed loss of voluntary motor and sensation, and that can vary as well within that. And then urinary, again, this is the injury at T1 to L2, so we're going down further. You're going to see retention, flaccid bladder, especially in that acute stage, that initial injury stage, okay? In the later stages, they're going to have spasticity and reflex bladder emptying, okay? And we're going to see with some of the complications how this plays a role in either neurogenic shock or the reflexia that we'll go over, okay? The hyperactive reflexia. And the GI as well will play a role in that. So these two are really huge. So decrease or absent bowel sounds. And again, that's injury above the T5. And you're going to see that paralytic ileus, okay? Because remember, you have paralysis of the muscles outside and inside. And you're going to see abdominal distension and pain, constipation, fecal impaction, and incontinence. And then the skin, this is a neat word. It's poikilothermic. It's the inability to regulate their internal temperature. And they're going to be warm or dry below that injury. And that's usually from that neurogenic shock. And they do have a potential for skin breakdown as well. So they're not going to be able to sweat. They're not going to be able to shiver. And these three over here, I really like to include it just because of the complications that can cause for these to occur. So you'll see that neurogenic shock, if there's a full bladder or impaction, and especially that autonomic hyperreflexia, even the skin, because they can't feel, they're paralyzed. You can have the bedding way too tight across their lap. So I have another PowerPoint slide that's going to discuss that a little bit further. But I really wanted to just kind of get this all out here. It's more of the importance altogether. And then we're going to go ahead and deep delve into it individually and more thoroughly. The neuromuscular, how that's affected during the spinal cord injury. So just think about that for a minute, where everything is affected. Especially when that patient has absence of sensations. And we really want to prevent that sensory deprivation. So we need to compensate for that. Okay, we want to provide stimulation. Because if the earlier on we do it, they have a better recovery of that. Especially if it's an incomplete injury. Okay. So what we want to do is, stimulate that patient above that level of injury. So things like conversation, music, having interesting food. This can be part of that nursing care plan where you do things like provide a person a glass so that that patient, their glasses or the prism glasses, so they can read and watch television. And, so if they're laying down, they can see at different angles because they can't move their neck. They can't, you want to build new neural pathways. That's the whole point of it. Okay, we always want to do it. Even if they're paralyzed from the neck down, you still want to provide some stimulation, okay? Don't ever think that because you can't, they can't feel from the neck down, you don't do anything with them. That's not true, okay? The whole point is we want to make every effort to prevent that patient from withdrawing from their environment. So making that environment adaptable for them so they can still function onto some of their abilities that they do have left, okay? And these patients with spinal cord often report that they have an altered in sensory, okay? And they might even have vivid dreams during that acute phase of the injury, okay? And it might even be some of the drugs that we use to manage it as well, all right? And they might, experience sleep disruptions because of the hospital environment or that post-traumatic stress disorder due to their injury. And once that spinal cord shock is resolved, then we have that return of reflexes. And that might actually complicate the rehabilitation because now they lack control from their higher brain control centers. And their reflexes are going to often be hyperactive. And so they're going to have exaggerated responses. And that sometimes can be an issue, again, with rehab. With these patients, we also should be, aware that they're going to have uncontrollable erections, especially of the male patients, of course. And that just occurs from a variety of stimulus, and sometimes there might be some embarrassment or discomfort. If this happens, they might have some spasms that range just mild twitch, and they may be convulsive as well, okay? So we just, it's a natural and normal thing. We don't want them to feel too embarrassed by it. I mean, no matter what, they're probably going to feel embarrassed just thinking about that, All right. And explain the reason for some of the activities that we are doing that. We want to inform the patient of the positive use of their reflexes, and especially when we're doing bowel or bladder training or retraining, I would say. And if they're having spasms, they may be controlled with some antispasmodic drugs like baclofen or Dantrium. And sometimes they might have some severe spasticity. And we can treat that even with Botox injections. Kind of neat when you think about that. And then sometimes they can have surgery done in an attempt to remove a foreign object, if there's pieces of spine in there, or injury loss or bullets or bone fragments. A laminectomy, they might perform that where they remove part of that laminate from from that bone. And it's the bony part of the spinal column, and it's, usually they remove it because it's pressing down on the spinal cord, okay? And then the other management might be maintaining that patient in a neutral position. We want to do the log roll when we're transferring them. At all times we want to keep them immobilized, okay? We don't want them to move. And sometimes they'll do some compression therapy as well. All right, so we just really want to look over all of these and consider what we're going to have to do for their neuromuscular system, okay? Interventions for spinal injury. So these are non-operative treatments, and the primary focus is stabilizing that spinal cord segment and decompression. So we want them to be immobile, okay? We want stabilizing method will be trying to eliminate any sort of damaging motion, like that's twisting, because we want to prevent further injury. Okay, so these methods are intended to prevent that secondary spinal cord damage. And for cervical injuries, you'll see skeletal traction. And it's not very often, but sometimes they will still use that. But they have other options that are better and more surgical options for stabilization. You know, the book did mention like Crutchfield or Gardner Wells. Tongs or other types of devices can be used for traction. And this is a traction device as well. It's the tongs. And of the two, this one is the worst. Sorry, let me get my pointer right here, because there is a weight and that is screwed into their head. And you know what it does is keeps that spinal cord in line. This, at least the patient can move around. It's not comfortable by any means. I mean, they're both screwed into their head. I mean, it's just to completely keep them immobile, you know. And you're going to be concerned about, you know, infection and anything else. And this, their comfort level. And then you have these hard C brace or hard cervical collar right here. And then here is multiple people doing a log roll. And that's just to keep that spinal cord in alignment. We don't want them to move or do anything. So this is the strictest alignment that you can have. And you could just see they look uncomfortable. And the device is very heavy, so they can get a lot of fatigue just wearing it. Okay. Our respiratory assessment is going to be one of our higher priorities here, just because it's the AB of the ABCs, okay? And our respiratory complications are going to correspond to whatever level that injury is. So just remember that. Cervical injuries that occur above that level of C4 are going to have special problems just because of that total loss of respiratory muscle functioning. And these patients are going to need mechanical ventilation just to keep them alive. And remember, at one time, the majority of these patients died at the scene from these injuries. But since we've come a long way and we have more medical improvement in the emergency service departments, most of these patients are able to survive. And that really does begin with initial treatment on the scene. Now, if we have an injury or fracture below that level of C4, it can result in issues with that diaphragmatic breathing. It impairs that phrenic nerve functioning. And just think about the secondary spinal cord injury, you know, all the edema, hemorrhage, that can affect that functioning as well, okay? And it's going to cause respiratory insufficiency. And we're going to see hypoventilation. And hypoventilation almost always occurs with that diaphragmatic respirations, you know, and that paralysis of the abdominal and intercostal muscles. And so we're going to see a decrease in that that vital capacity and that tidal volume. And we have impairment of those intercostal muscles. And we're not going to have an adequate cough, you know. And you're going to see paralysis of abdominal muscles, you know. And these patients simply, they can't cough effectively enough to remove any secretions. And they're going to be at risk for atelectasis and pneumonia. Okay? And if we have an artificial airway, they're going to be exposed to direct contact of pathogens. So it's really important that we have that bronchial hygiene and doing that chest physiotherapy. You know, performing this function is going to be important in maintaining and reducing infection. And then there's a risk for neurogenic pulmonary edema. And this can occur secondary to that dramatic increase in the sympathetic nervous system activity. And that usually occurs at the initial time of injury. So that fight or flight response, okay? And with that neuron, the neurogenic pulmonary edema, it's going to shunt blood to the lungs. So in addition, this pulmonary edema can occur, and it's going to cause some fluid overload for these patients. Okay, that's kind of scary. And part of these assessments with these patients is going to be regularly assessing their breath sounds, assessing the ABGs. We're looking at those breath sounds, are there crackles? Are they going into that neurogenic pulmonary edema? Are their arterial blood gases abnormal? Are they getting acidotic? Okay. Assessing that tidal volume capacity, looking at the skin color for any signs of hypoxia, are they pale? Are they turning cyanotic? Assessing those breathing patterns, look and see, are they taking really shallow breaths, and listening to any subjective data that, might give you clues to their ability to breathe, and looking at, if there's any sputum, what is the color? What's the amount that's coming up? How thick is it? And then we can look at that partial pressure oxygen, and it should be greater than 60. And that partial pressure of carbon dioxide, that should be less than 45. Those are acceptable values. Patients with any uncomplicated quadriplegic, we're going to do a quick assessment, okay? Is this patient unable to count to 10 without taking a breath? Is it taking a really long time just to count to 10? You should be able to do that without being out of breath, okay? And if they can't do that, they're going to need some kind of attention, In addition to monitoring, you can also intervene to maintain ventilation. And this is aggressive chest physiotherapy, so we're cupping them. You want to get adequate oxygenation, making sure that they're treated for pain, okay? All of these things are going to help maximize that respiratory function and help with gas exchange. And these patients, they're going to get oxygen therapy until those ABGs have a chance to stabilize. The chest physiotherapy and cystic coughing are going to help facilitate getting some of those secretions out. So remember the cupping of the hands where you do on the back and the lungs. That's going to help it get out. And then there's also something called assisted coughing. And it stimulates the action of coughing, if you have that ineffective abdominal muscles and you cannot get enough during expiration. And the way that you would do this assisted coughing maneuver is to place both of your heels of your hands, both of them, just below that xiphoid process, almost like the Heimlich maneuver, okay? And you're going to exert a firm upward pressure into that area, and you have to time it with the patient's effort to cough. So you guys are going to have to be on the same page. You're going to have to say, okay, when you cough, we're going to cough, okay? Cough, and then thrust. Cough, thrust, And that's that assisted or augmented cough, okay? And if the patient has a trach, then we're going to perform tracheal suctioning. If there's any sort of crackles or bronchi that are there, we're going to teach them to do the incentive spirometer because we want to expand their lungs, okay? And that's really important to help prevent the atelectasis or pneumonia, okay? Cardiovascular. It's any cord damage or injury above T6. And this is greatly going to decrease the effect of that sympathetic nervous system, okay? And that parasympathetic nervous system is going to become unopposed. So you're going to see that bradycardia. There's going to be peripheral vasodilation that leads to hypotension. And they're going to have decreased venous return of the blood to the heart. And that's going to cause decreased cardiac output. And that leads me to deep vein thrombosis. And just think about all that stasis of blood that is going to cause embolotic or thrombolytic formation. So they're going to form blood clots, essentially. And they can get a pulmonary embolism. This is the leading cause of death, especially that first 3 months. And why it's a leading cause of death is because it's harder to detect because they don't have those signs and symptoms that they're able to detect. They don't have that protective mechanism that's a warning. Pain is a warning. Numbness, things like that are warnings that something is wrong. Difficulty in breathing, So if they have, paralysis of the chest down, they're not going to be able to detect that. And especially deep vein thrombosis, they can't detect that pain in the calf either, So that is very, something that is a high risk for death. That's the leading cause of death is a PE. Okay. And some of our management, we are going to do cardiac monitoring. It is absolutely necessary. I mean, think about that bradycardia. And we're going to give them atropine. That's just to increase that heart rate. Okay. And we're going to give IV fluids or vasopressor drugs because we want to keep that systolic blood pressure over 90. Okay. And we're probably going to, in that very acute phase, give that vasopressor dopamine. We want to get the MAP greater than 60. We want to get more perfusion to that spinal cord. Okay. And we're going to do frequent vital signs on these patients. And they might have to get a pacemaker, especially in that early phase. I mean, if you got a couple of months and, you have that immediate effects of that sympathetic nervous system being absent to counteract that, you have to keep that heart rate over 60. And again, with the DVTs, we're going to do sequential compression devices, heparin, Lovenox, and then do those daily range of motion exercises. Okay? And also, one thing you really got to be careful about is that we have unopposed vagal response. And just think about that for a minute. Parasympathetic and sympathetic nervous system work together in tandem, okay? And remember, vagal response is part of that parasympathetic nervous system. So turning that patient or suctioning them can lead to a cardiac arrest, okay? And just because we're stimulating that vagal response. So be very careful and conscientious when you're taking care of these patients. Assessment of the urinary, especially in the acute phase because they have a loss of the autonomic system, you're going to see urinary retention. And they're going to have bladder atony, and it's going to be over distended, and they have a risk for it to rupture. Okay? And so you're going to see an indwelling catheter placed, and the nurse's role is to make sure that it is patent and irrigated, and we want to make sure that we're assessing the output and make sure that we're looking for signs and symptoms of infection. We want to avoid those CAUTIs, so strict asepsis. And we want to give them large fluid intake. Now, the post-acute phase, the bladder may become hyperirritable. You can see that neurogenic bladder, where they just have that loss of inhibition from that brain. And that neurogenic will have like urgency, frequency, and a lot of incontinence. And all of that bladder pressure can reflux into the kidneys, okay? And then you have that reflex emptying. So again, just because it's so common to get UTIs, we really need to regularly and completely drain that bladder, and whether it be indwelling or straight cath. And a lot of times we're going to have to teach the patient on how to do this, and depending on where that injury is, that we can even possibly have bladder training. But like we said, that acute phase, we could have that indwelling urinary catheter, absolutely strict aseptic technique because of those CAUTIs. And we want to increase that fluid intake. We want to flush them out. Just think of it that way, okay? And then we're going to have an intermittent catheterization program. So every 3 to 4 hours. And then we're going to teach them to monitor for signs and symptoms of urinary tract infections. I mean, us ourselves, we're going to be looking for that. And we know by just looking at the odor cloudiness of it? Is it bloody? Is there traces of blood or sediments? The patient, they're not going to be able to tell you if it's pain or burning. Those are some signs and symptoms of an infection. So we have to rely on other senses, okay? And then the ongoing phase, we want to monitor those I's and O's, monitor for urinary retention, and again, teach self catheterization if that bladder becomes neurogenic, okay? So they're going to have to, do it themselves. They're going to have to do it every 3 to 4 hours, okay? And then some drug therapy is anticholinergics, alpha adrenergic blockers. We can do surgery like a sphincterectomy or electrical stimulation as well. Some major consequences of the integumentary system or their skin is the fact that they just cannot move. So it's going to lead to more skin breakdown, especially over those bony prominences. And they just simply cannot fill that area. So these patients are going to be at higher risk for pressure ulcers, and they can happen quick, and they can lead to infections and possibly sepsis. All right. That's why it's so important as well to have that active range of motion, not just for the prevention of DVTs, but for the skin breakdown, okay? And poikilothermism is a really funny word, but this is just really the body's inability to adjust their temperature. Okay, so when they go into a room, their body cannot, adjust accordingly. So you're going to see it because it's an interruption of that sympathetic nervous system. So they have that decreased ability to sweat or shiver. And it's more common with the high cervical injury. So we are not going to overload them with covers. We're not going to expose them fully like during taking a bath. We're going to have to teach them, to dress appropriately. If it's winter out, dress as so, and put boots on and, protect your feet. Okay. And so no vasoconstriction leads to piloerection or heat loss through perspiration. So they're not sweating below that level of injury. So it really depends on the external by that patient. They have to control that temperature. So if they're, waist down, again, they're going to have to, they might wear a sweater and shorts. You don't want that. They have to cover their legs. They have to wear, warm socks and, make sure that they don't get wet and to constantly assess that, because that management, they have to manage that temperature through external means, okay? And think about if they do get an infection, they're going to have a high fever, and it's going to be more extensive because it needs to be controlled. Their body can no longer do it on their own. So we're going to monitor their environment, have them, make sure the room's not too hot or too cold for them. And then we're going to, monitor their body temperature. And again, we're not going to overload or, expose the patient constantly. Assessment of the GI. Above the T5, the primary G problems are going to be related to hypomotility. And that's where we're going to see that paralytic ileus. And we'll also have some gastric distension. And with these patients, they're probably going to get like an NG tube with intermittent suctioning to help relieve some of that gastric distension. Reglan is also another medication that can be used to help treat some of that delayed gastric emptying. Stress ulcers is common as well because of that excessive release of hydrochloric acid in the stomach. If the patient has some intra-abdominal bleeding, this can be really difficult just to diagnose because these patients with these injuries have no pain or tenderness. And I would normally, that could normally signal that some sort of internal injuries are going on, but they can't, So we're going to be looking at those vital signs. And if we see this continued hypotension, and in spite of treating it, and we see that their hemoglobin is decreasing or the hematocrit, we might need to further investigate this, okay? And there could be some indications of bleeding there. And we're going to look at the abdomen itself, and that, if that girth is starting to expand, then we might have some abdominal bleeding. You need to really ask yourself that, is this, because of that voluntary neurogenic control, all right, over that bowel. That can result in that neurogenic bowel, okay? And in the early periods after injury, when we still have that spinal shock that's present in the patients with these injuries of T12 or below, all right, so we're going to see initially bowel areflexia with decreased sphincter tone. Okay, and as these reflexes start to return, we're going to see that sphincter tone is enhanced. The bowel is going to be more, ready to empty, so we're going to be on the lookout for those. Because both our reflex and reflex neurogenic bowel can be managed with using some sort of regular bowel program. So we're going to coordinate that gastro-colic reflex, to minimize any sort of fecal incontinence, because these patients can't have any oral take. So we're going to want to watch their fluid and electrolyte imbalances. They're going to have specific solutions and additives that are ordered based on those individual needs. Once the bowels are, during the injury, they can't eat or drink initially, but this is directly after the injury, once these bowels are present or the flatus is passed where they're passing gas, then we can restart them on the foods and fluids, okay? And gradually, you just want to start them slow. You want to slowly introduce them. Because of the severe catabolism, we're going to want to give them high protein, high calorie diets necessary for that energy. Okay, because that body is in constant metabolism mode, okay? That needs it because that body is constantly repairing itself. And with these patients with a high cervical cord injury, you want to make sure you're evaluating their swallow before you even start them on some sort of oral feedings or liquids of any types, okay? And if they're not able to resume feeding on their own, we're going to have to, get them some type of nutrition, whether it's enteral or parenteral. We're going to, make sure that we get that within 3 days and get them up to their potential by 7 days, okay? You can even have to give them a PEG tube or of some type, okay? And then the bowel program started during the acute care. That's where they're going to have that daily rectal stimulant, digital stimulation, or manual evacuation. We're going to keep them in an upright position when they're able to, because that helps them to empty their bowels, okay? So just remember, they just don't have that sensation that they have to poop like you and I do, okay? And, we're going to monitor their stool, their gastric contacts, and, of course, the hematocrit, their H&H, okay? Just because of that GI bleeds or intra-abdominal bleeding. And then we're going to want to give prophylactic medications like protonics for the stress ulcers and maybe some stool softeners, okay? With metabolic issues, just the whole sum of this slide is, take anything away from it, is that the body is in constant state of repair. And it gets into this like hyper metabolic state, okay? They're going to become fatigued easily because of the amount of energy expenditure. And you're going to see weight loss. And as a nurse, you want to give them calorie meals. And you want to keep their nutrition to an optimal level. And honestly, like from the prior slide for the GI, you really want to get them started within 3 days if they're able to eat, and kind of get to their nutritional optimum nutritional level by day 7. Okay. But there are some other concerns with that we need to be on the aware of during assessment. And if they have an NG suctioning, we know that causes metabolic alkalosis. So we're getting rid of all that acid out of their stomach. So all those hydrogen ions, okay? And we'll start seeing, because of the tissue perfusion is going to be decreased, we're going to see some acidosis, okay? And then you have electrical imbalances. Again, sodium, potassium are the biggest ones. They can be altered because of that gastric suctioning. And especially potassium with any type of acidosis or alkalosis. If the pH is down and they're acidic, the potassium's going to be up. If they're alkalytic and the pH is up, then the potassium's going to be down. All right. So just be aware of that until that gastric suctioning is no longer needed. The patient's able to tolerate normal diet again. We really want to be aware of the weight loss. What is causing it, especially if it's greater than 10%. Some of it could be psychological. They could have some type of power control because that's all they have left. Just think about that. You have no control of your body, and maybe the only say you have is what goes into it. So we really had to do a thorough assessment and see what is causing the weight loss, whether it be just their high caloric need because of the energy, the high catabolism that's going on, or they're depressed, so it really has to, ask why is this happening, assess the cause. And if it is something psychological, maybe sign a contract with that patient, and keep their environment very pleasing, and have high calorie count, and supplement with nutrition and supplements and vitamins if needed. And again, we want to increase that dietary fiber, okay? And see what they like, let family members bring that in, So, yeah. Drug therapy interventions for spinal cord injuries. Steroids are no longer recommended just because they're associated with a lot of side effects. Like GI bleeding, especially immunosuppression. They can lead to sepsis. They just have so many risk factors that they end up going into the ICU and have longer stays, and it can even lead to death, okay? So these are like no longer recommended. I'm just going to cross it out. No more steroids, okay? And atropine, that is used to increase the heart rate if they have that severe bradycardia, less than 60. So just remember that during that spinal shock, it has unopposed parasympathetic nervous system. So that flight or fight is no longer in. So you don't have that sympathetic nervous system to increase the heart rate. So you just have vagal response in this parasympathetic nervous system, the rest and digest. So it's slowing the heart rate down. So atropine can actually reverse that. Dopamine is our therapeutic adrenergic vasopressor. It's going to be used to maintain that blood pressure and help with increasing cardiac output in that neurogenic shock. So just remember that they have not only low blood pressure or low heart rate, but low blood pressure, okay? And we're going to have to closely monitor them with that because safety is one of our main concerns, okay? Uh, dantrolene, dantrium. This is actually one of those CNS depressants. You know, it's our goal is going to be to reduce muscle spasms that occur due to that motor and sensory pathway interruption. And we need to get some kind of a balance. And so dantrium is used for that. And so, of course, we want to be careful with safety of that. And then, dantrium again, it's one of those direct acting muscular skeletal relaxants. It's going to decrease the release of calcium from the muscle cells. Okay. And baclofen, that is an antispasmodic. And that's also used to help control spasms. And it works by inhibiting those reflexes at the spinal level. It can also help or be used to improve the bowel and bladder functioning in patients. I mean, you more often see it with MS, but it is also used for spinal cord
patients,
injury as
their
well.
rehabilitation process is going to be very complex. So with physical and physiologic care and intensive specialized rehabilitation, these patients can learn to function at their highest level of their wellness. So we kind of involve a lot of different processes going on here. It's recommended with all patients with a new spinal cord injury receive that comprehensive inpatient rehab in some sort of rehabilitation unit or a center or something that specializes with spinal cord patients specifically. A lot of the problems that are identified in that acute period can become chronic and continue throughout their life. So the rehabilitation focus is going to be on retraining of those physiologic processes, and it's very extensive for the patient, the caregiver, family members. The teaching about how to manage these physiologic and life-changing results is going to be a big focus of their overall rehab. With rehabilitation, it's a big interdisciplinary endeavor, and it's carried out through a big team approach. So we might have team members like a rehabilitation nurse, we have physicians, we have physical therapists, we have occupational therapists, speech therapists, there are vocational counselors, we have psychologists, therapeutic recreation therapists, we have the prosthetists, the orthotists, and dietitians. So there are lots of different team members all working in conjunction with each other to get this patient restored to their maximum amount of function. So our rehabilitation care is going to be organized around that individual patient's goals and their needs and their abilities. So during rehab, these patients are expected to be involved in therapy, and it's not just the therapist kind of working their doing the therapies for them. It's an opportunity for these patients to self-learn these activities as well. And it's usually pretty involved where they're there. It's several hours each day that they have this intense therapy. And if you think of what this patient is dealing with mentally with this sudden change of health and their function, and then you add this really intensive work on top of it, it can add a lot of stress onto these patients. It can add a lot of frustration also because they might have progress that's really slow. So that is why that team approach and having all these team members and the experience of them is going to be real important in providing that encouragement. This is a specialized nursing care that the patient and the caregiver, they're going to need all that teaching. They're going to need a lot of help with coordinating the efforts of the rehab team, but also coordinating how are they going to prepare for when this patient goes home. So it is a very specialized area that involves a lot of expertise and keeping in mind a lot of those psychological aspects of rehab as well as the functional and physical aspect of it.